two health insurance plans is Fred Schaefer. And Fred is with Boucher, Millett, and Schaefer. They're the consulting firm that works with our BOCES Health Insurance Consortium. And how many years have you been doing that?
Well, since 2008 as a consultant.
Uh-huh.
Since 1996, I was with Empire, and my team handled the health consortium. So I've actually been doing it since 1996 in one form or another.
That's quite a bit of experience. So I'll turn it over to you, Fred. Thank you.
Okay, very good. Good afternoon. So, quick question. All of you are enrolled in in the alternate PPO now?
Mm-hmm.
Okay. Or the HRA, one or the other, right?
Yeah.
Okay.
Some.
Just wanted to make sure we didn't have people that were looking to.
There's at
join
least
the
a couple of people here that still have the PPO, but as of June 30th, that goes away.
That goes away? Okay.
July 1st.
Okay, very good. Well, as Lynn said, I'm Fred Schaefer, I'm the consultant, and we just talked, I've been associated one way or another since 1996. Lake George is one of the school districts in the health insurance trust. So there's 29 districts plus the BOCES itself. So you're part of a group that's over 18,000 members and over $130 million in claims. So you're in a good sized group, which helps with stabilizing rate increases and leveraging expenses with Empire, Blue Cross, and what have you. So that part of it is a good thing. Do I have a remote, or do I just hit the arrows here?
With arrows, it's gonna work. I can grab you a remote if you would prefer.
I'm flexible. So anyway, today, just gonna talk a little bit on the basics of the PPO, and then we'll get through the benefits of each plan. I'm not gonna spend a ton of time on the alternate PPO, but if you have questions, I'll be happy to take them. The alternate is a copay plan, so it's relatively simple. And then the HRA is a little more complex, and I wanna spend some time on that to make sure everyone understands how that works. So PPO, Preferred Provider Organization, is what PPO stands for. Basically just telling you that you have a network of doctors. And if you stay within that network, you have lower out-of-pocket costs than if you go out of the network. You still have freedom of choice. You can go out of network, but you will pay more, and we'll get to that. I get some questions about referrals. No referrals are required on either of these plans, meaning you don't have to go to your primary care physician to get to a specialist. You can just choose your specialist and go. And no claim forms if you're in network. And deductible and co-insurance, which we'll talk a lot more about in a minute, if you do go out of network.
You ready to?
Yeah, you can see the sign. Okay. So the network. As I just said, I'm going to move this a little bit. As I just said, if you stay in network, it's low out-of-pocket cost. The trust as a whole, $136 million in claims, thereabouts. We see a couple, 3 percentage points out of network, not a lot. So everyone's doing a really good job staying in network. It is the largest network in the country, and the reason for that is all the Blue Cross Blue Shield plans across the country have united to form one national network. So if you're in Florida for 6 months and you need to see a doctor down there, you can see the Florida Blue Cross Blue Shield doctor in their PPO network, and you will remain in network as far as Empire is concerned. If you have a dependent that's in college or something and lives out west, wherever they are, the local Blue Cross Blue Shield plan PPO network will be in network for your dependent. So it is a large national network. Any questions? Oh, okay. Any questions on the network before I move on? Actually, I noticed, I apologize, I have some retiree slides that I would have put in here, but I wasn't aware. I thought we were just going to be employees at this point. But for you retirees that are Medicare primary, obviously you can see your Medicare doctors, and then they'll pay, and then the balance will roll over to Empire, and that should be an automatic rollover. You shouldn't have real issues with that, but we'll talk more about that when we get to the balance. So, HRA or alternate PPO. Just some of the basic questions that I get most every presentation, so I just wanted to cover them up front. The provider network is the same. So if you're in the alternate PPO and you move to the HRA plan, it'll be the same exact doctors in network, both locally here for Empire and nationally. Okay, so there'll be no disruption there. Same medical policy. Empire only has one medical policy, and I'm talking for, if you have a unique illness and it's covered under the alternate, it'll be covered under the HRA, vice versa. There's only one policy. So medical criteria bases that they use to judge whether or not they will be paying on that service will be the same for either plan. If it's covered under one, it'll be covered under the other. It's going to pay a little bit different because they are obviously different benefits. Pre-certification requirements are the same for both plans. And if you're Medicare primary, you do not have to pre-certify with Empire. For those of you that are under 65 or still actively working, pre-certification requirements are required. They're in the booklet, the information is there, a lot of information. They call it, Empire interchanges the terms prior authorization and pre-certification. So in the booklet, they're prior authorization at this point, and there is a list. So if you're subject to that requirement, make sure it's done. I'm gonna say 99% of the time, the provider does it for you. But if you are required to pre-certify a requirement or a service, you need to make sure it's done because there is a penalty if you don't have it done. But again, if you're Medicare primary, you don't need to worry about that. Paid full preventative benefits are the same on both plans. There's no impact on either plan. They are just paid in full by Empire. Health and wellness plans available on both plans are the same, with one exception. The HRA does have a fitness reimbursement that we'll talk a little bit about as well. The vision benefits are going to work the same way on both plans. You still have the Blue View Vision benefit for routine eye care with the $135 allowance for the lenses plus 20 for the frames plus a 20% discount. That information is in that booklet as well, and it will work the same for the HRA, even though there's a deductible on the HRA that I'm going to talk about in a minute. And last, the prescription drug formulary. Now, I'm talking about the actual formulary of drugs that Empire covers. So if you're in one plan and you have a couple of generic prescriptions you get, if you move to the other plan, it's going to be still tier 1 generic prescription. So all the tier 1s and that you currently have will be tier 1 in either plan. Same with tier 2, same with tier 3. So the formulary is structured the same. There's only one formulary. Okay, the co-pays will be different, and how it pays on the HRA is going to be different. But if you are taking prescriptions that are in tier 3, they'll be tier 3 no matter if you stay in the alternate PPO or move to the HRA or vice versa. Okay, any questions? No. So alternate PPO plan benefits. There's just a brief summary. There is a benefit summary in the booklet. I gave you each 2 booklets because one is for the alternate PPO and the other one is for the HRA. They're similar. The information is very similar, but the benefit summary is different. Fitness reimbursements in the HRA, and obviously the benefit summaries are obviously different. But as far as the alternate PPO benefits in network, hospitalization, inpatient, outpatient is paid in full. Emergency room's a $200 copay. If you're admitted, it's waived. But if you have to be admitted. Sometimes you're held over for observation, but not truly admitted. And in that situation, the copay would stand. Even though you were overnight in the hospital, you weren't technically admitted. Okay? So that does happen occasionally. Urgent care facilities, and there's a list of those in the brochures, $50 copay. The office visit copays are $30 or $50, so it's a split copay, depending on the provider you're seeing. I'll talk a little bit more about that in a minute. Preventive Services I talked about, 100%. Your prescription drug copays are $10 for tier 1, $25 for tier 2, $50 for tier 3. And that's what we were talking about with the formulary. So there's 3 tiers in the formulary. If you're on a maintenance medication or a chronic medication, you can get a 90-day supply if you get a prescription from your doctor, and it's 2 copays for the 90-day supply with the ultimate PPO. So you can save a copay every quarter. We talked about the network. No lifetime maximum. You can't run out of benefits on either one of these plans. If you go out of network, there is a deductible of $200 per individual, up to $500 for the family. And then Empire's gonna pay 80%, and you as a member would pay 20% of, up to their allowed amount. There is an out-of-pocket maximum, which is $1,200 for the individual, $3,000 per family. And their 80th percentile, which is the 80th percentile. It's a typical, usual, reasonable, customary allowance. However, if you do out of network, remember you're subject to balance billing. So, a quick example. If you go to say someone goes to a Park Avenue doctor for an office visit, that doctor may charge $500 for that office visit. Empire's allowance on that visit may be $300. Just an example, I don't know what they would be, but this is just for an example. Say their allowance is $300. So Empire's gonna pay according to a $300 allowance that they have allotted for that service. So if you've already hit your out-of-network deductible, they're gonna pay 80% of that $300, which is $240. You'll have a $60 liability. However, that's only $300. That out-of-network provider is gonna charge $500, so he's gonna charge you the extra $200 too. So that's some of the savings you can have if you stay in network. So that's always the case with balance billing with out-of-network providers. And typically, most of you out-of-network providers are probably because they don't like the allowance that they're getting by being in network. So, office visits, the split copays, 30 or 50. So the $30 office visits are for your primary care physician, OB doctor, a midwife, when needed, chiropractor, mental health, and what Empire calls in-office physical therapy, occupational speech, and vision therapies. Which means, as long as you're, say, physical therapy, you're going to a physical therapist, they own their own practice or in their own building, what have you, $30. Some people, especially downstate, we see this, not so much up here, but downstate, some people go to an outpatient hospital setting for physical therapy, and in that case, it would be a $50 copay. Because it's not in an office, it's a facility charge, basically. Now, we may see that with some of the hospitals that own physical therapy offices here too, because if they bill as a hospital, that's gonna be a hospital outpatient setting, which means it'll be a $50 copay. All your other office visits, your specialists, your orthopedics, your cardiac doctors, anything other than that set of doctors will be a $50 copay on the ultimate PPO. Any questions? You're awful quiet. Yes.
I'm curious if you could just share what is a preventative service. Just give me an example.
Your routine, your annual routine physical is a preventative service. So when you go to get your physical, any blood work attached to the physical, yeah, you need one of each.
Thank you.
Any blood work, any of that associated with the physical would be, if the provider will bill that and code that as a preventative service, then Empire will pay that in full. So there would be no copay there. Here's a tricky one, a routine colonoscopy. So people hit their benchmark and they go for a routine colonoscopy. That's gonna be paid in full. And then If everything's fine, there's no polyps, nothing, you'll have another one in 10 years, that will be routine. But if the doctor finds polyps and he says come back in 3 years or 5 years, that's gonna be diagnostic, okay? So then that's not gonna fall under preventative. And just so you know, in the brochures, there's a good list of all the preventative services. There's also some preventative prescription drugs that are no co-pays, and they're listed in the back of that brochure as well. Anything else? Because I'm going to move to the HRA, because that's gonna take a little longer to get through.
Can I just grab two of those?
Mm-hmm.
Several. One of each. Thank you. Thanks.
What does HRA stand for?
Oh, I'll get to that, but that's a good question,
Sorry.
because that's coming up next. HRA is Healthcare Reimbursement Account.
I knew it was help something.
Mm-hmm. So yes, that's what we're gonna be talking about that in just, if there's no questions, I guess we'll move on. So yes, HRA, it's still a PPO, but attached to the PPO, there's a healthcare reimbursement account. So with this plan, this is not your copay plans that you're used to from before. This plan's been offered in the trust for, I'm gonna say at least 10 years now. And in the last 3 or 4 years, it's picked up momentum. There's a lot of movement to the HRA plan. So with this plan on in-network, there is a deductible. So it's $1,500 for an individual contract, $3,000 for a two-person or family contract. Okay, so the two-person and family contract, the benefits are the same. It's double the individual, and that's just how this plan's always been set up. Actually, most deductible plans are set up this way. So you need to meet the $1,500 deductible or the $3,000, depending on your contract. Let's just say an individual, a single person on the contract, need to meet the $1,500 deductible before the PPO benefits kick in. But with that, the district will pay the first $1,000 of that $1,500 deductible. And they'll pay the first $2,000 on a two-person or family. So they're gonna pay 2/3 of the deductible, whether it's an individual, two-person, or family contract. Then, after the deductible is met, the co-insurance starts. Now, there's no co-pays here on anything that's a medical service. It's 10% of Empire's allowed amount that you would pay, Empire would pay 90. The prescription drugs after the deductible are $10 for tier 1, $20 for tier 2, and $40 for tier 3. And once you hit the deductible, the mail order would be 2 copays for a 90-day supply again, just like with the alternate, after the deductible. And I'm gonna get into the deductible, how that works in just a minute, because I'm gonna walk you through 3 or 4 different phases of the HRA.
I just have one question.
Sure.
How's this coincide with Medicare?
Basically, it's gonna work the same way that it does with the alternate. They're gonna pay first, and then the balance
Okay.
will roll to Empire. And I'll talk about that a little at the end, once I get through the different scenarios of this. But that, it will work basically the same, but this plan design is obviously quite different than the alternate PPO with the copays. There is a safety net, so out-of-pocket maximum, $2,425 for the individual contract, $4,850 for a two-person or family contract. What that means is, now most people don't hit their out-of-pocket maximum, but if they do, for the rest of that contract year, if you stay in network, Empire's paying 100%, meaning you would have no out-of-pocket in network at all. And that would be for, including your prescription drugs, copays, they'd be gone as well. So once you hit that safety net, it's paid in full for the rest of the contract year. Now the contract year is July through June, so it would be through the end of June. I'm gonna talk about this a few times going forward, but that's just to let you know. Question?
I'm looking at the booklet, page 15, where it's
It's 6580.
It's, yeah, and on the individual, 3425.
Yep. Yes. And I'll explain that, my next slide explains it, but basically, the reason for that is the second line, the employer contribution, because that first 1,000 of that on your employer, that 3450, the district's paying, so your true out-of-pocket
Is that?
is that. Now I wanna touch on the out-of-network here. I'll explain that a little bit more in just a minute, but, the out-of-network on the HRA is a little different than the alternate as well. So that deductible, that 15,000 or 1,500, 3,000 deductible, that's a separate deductible. So if you've met your in-network deductible and then go out of network, there is another deductible to meet. If you decide to go out of network. If you start out of network for some reason, any money that's applied to the out-of-network deductible will be applied to the in-network deductible. But it doesn't work the other way. If you're in-network, any money applied to that in-network deductible will not be applied to the out-of-network deductible. And that's because if you, say you're out of network and you wanna come back in-network, but you haven't met your in-network deductible, the plan doesn't wanna penalize you for going back in-network because it'll save you money and the plan money. But if you go out of network, it's a separate deductible. Then, once you meet your out-of-network deductible, you're gonna pay 30%, not 10 like in-network on the HRA. Your out-of-pocket maximum you'll see is much higher, 7,500 and 15,000, that's individual, and then family maximum. The reimbursement out-of-network's a little bit lower, and balance billing's still going to apply. So, but again, we have over $130 million in claims. We see a very small percentage out of network. And some of those claims are actually paid in network, even though they're counted as out of network. I'll give you a couple of quick examples. An ambulance. You can't choose your ambulance, and especially upstate, a lot of the ambulances don't even join a network, but the payment to the ambulance is paid as if it was in network, regardless of whether or not it is. Anesthesiologist would be another good example. You have surgery and you're in a local hospital that's in network. As long as the hospital's in network, there's a chance the anesthesiologist may not be in network, but they will still pay that claim as if you were in network with that anesthesiologist. Obviously, because you can't choose your anesthesiologist, as much as some of us would like to.
Can I ask you a quick question?
Sure.
On the HRA, preventative medicine, blood pressure, cholesterol, is that applied to the deductible?
If it's a preventative medicine that's paid in full, like you're talking about something that's on the list in the back of the book.
I know, I've just lived it, so like blood pressure medicine, was not applied towards the deductible, but applied towards the cap.
Okay. Yes. Can we hold off on that one a little bit?
That was this past year, 2 years ago, it wasn't.
Yes, because that's a new benefit. Actually, we added a benefit where we call preventative plus drugs. Preventative drug list there is paid in full, and it doesn't go toward deductible, doesn't go toward anything, it's just paid in full. Preventative plus bypasses the deductible, goes straight to a copay, and does apply toward your out-of-pocket maximum,
But not your deductible.
but not your deductible. So, yeah, let me get to that, and we'll talk a little bit more about that. So, I used to start a lot with the HRA just to kind of explain everything. And I go back and forth here a little bit. But you can see I have the deductibles up there, individual contract, two-person family contract, 1,500, 3,000. The employer contribution, 1,000 for the individual contract, 2,000, two-person and family. So let's just talk about, let's forget about Medicare for a minute and just talk how this plan's going to work. So say someone joins in July, an individual contract, they have $1,000 in their HRA, their Medicare reimbursement, the district will supply that money. So that is the first money used unless it's a preventative service. Like if the first thing you do is have your annual physical, nothing will come out of your deductible, or out of your HRA account, because Empire is just paying that in full. Nothing will go toward deductible, it's just paid in full, and it doesn't impact you. But say someone has a sinus infection in July. So someone goes to the doctor in July. When you check out, you're not gonna pay anything. I know you're used to paying a copay. This is not a copay plan, so you're not gonna pay anything. The provider will bill Empire. This is an old slide and I can't change the numbers in it, I'd like to, but this basically says Empire billed $100. Well, truth is they probably bill primary care visit $175 to $200. They bill Empire. Empire is going to adjudicate that claim, and they're going to adjudicate it down to the level that the provider has agreed to accept with their contract as paid in full, because they are in network with Empire. So Empire adjudicates the claim, they see $175, say no, you've agreed to accept 90. They're then going to look at the HRA account, see as an individual contract you have $1,000 in there, they're gonna take $90, pay the provider, they will send you an explanation of benefits showing the provider's been paid in full, and that $90 came out of your HRA account, you now have $910. Okay, so it's all integrated, there's nothing for you to do. Empire will track the account for you, and they will pay the provider, as long as there's money in the account. Okay, questions? So he gave you a prescription. Same thing happens at the pharmacy. You get your prescription, obviously, they go to the system, look your insurance up. It's real-time adjudication at the pharmacy with Empire's claim system. They will know, the system will know there's $910 in there. So at this point, you're gonna pay for the prescription, say it's $62 retail, but Empire has discounts at the retail pharmacies. So the pharmacies agreed to accept $36. They will take $36 from your HRA account, pay the pharmacy, and you'll leave. You won't have to pay anything, as long as there's money in the account. Okay, questions?
And it carries, right? If you have a balance at the end of the year, it carries over.
It does. The carryover is 2 times the contribution amount. So let's just say someone still had $500 at the end of June. That $500 in their individual account would carry over. They'd get another $1,000, and that year they would start with $1,500. The maximum they could carry would be $2,000, get another $1,000, and start with $3,000. That would be for an individual contract. A 2-person or family contract could carry over $4,000, get another $2,000, and start with $6,000. So it's always, and it will carry over every year. As long as you have money there, it'll carry over. It's not 2 years, it will carry over every year. If someone did get over $4,000, only $4,000 would carry, and they'd still get another 2 and start with 6 for the 2-person or family contract. Any questions? Okay, so that's how that would work. So now, if someone went for their annual physical, the same thing would happen. You wouldn't pay anything. They'd bill Empire. Annual physical, they'd bill somewhere around $300. It's a little more than just a level 1 primary care visit, office visit. Empire would adjudicate it down to whatever was owed and just pay it in full. You would not even get an explanation of benefits or an EOB on that, because it was just paid in full, and nothing happened with your HRA account. They didn't take any money out of it. Nothing went to a deductible. Empire just paid it. Okay? Okay, so this sounds great. It's a good plan. The next step in the plan is where your responsibility comes in. because you're in what I would call the bridge deductible at this point. Individual contract, you have a $1,500 deductible. Say you've used up the $1,000 from the district. So now you have $500, that's your responsibility. So that comes out of your pocket. Okay, so you have to pay that. Now, I guess the counterpoint on this is the premiums are much less on the HRA compared to the alternate. I don't know how much everyone has to pay, and that's the district's responsibility to explain, but I'm assuming there has to be some savings there. So with that, now if you go to, let's go back to the primary care. The same thing will happen, you won't pay anything when you check out. Now they're gonna send down that $175 bill. Empire's gonna adjudicate it, the doctor's still in network. Remember, I'm talking in-network providers. They're gonna adjudicate it down to say that $90. They're gonna look in the HRA account, there's no money in it. So now they're gonna say that goes toward deductible because you have a $1,500 deductible and you've only met $1,000 of it. So Empire's not gonna pay anything at that point. They're gonna send you an explanation of benefits along with the provider showing that you as a member owe the $90 and the provider will bill you and then you will pay the $90. Same thing at the pharmacy. Say that prescription, now you've used up the $1,000, that prescription's $62. When you get to the pharmacy, there's no money in the HRA account. You'll have to pay at the pharmacy. You'll pay the discounted price. You'll still get the discount, so it'll be $36, but you'll have to pay the $36 at the pharmacy. Okay? Questions?
And then everything that we're paying out is going towards that maximum out of pocket.
Yes, the $500 would go towards your maximum out of pocket. Yes, I need to explain this, because you were looking annual out of pocket maximum. So when Empire is looking at the claim system, they've loaded that for $3,425 for an individual contract, $6,850 for a two-person or family contract. But the district pays $1,000 for the individual, so that lowers it by $1,000 as to what you're actually paying out of your pocket. So that's why it's down to $2,425, and they're paying $2,000 for the two-person and family contracts, so that lowers that to $4,850. Does that explain your question? Okay. So the third phase of this would be you've met your deductible. So now you've spent $500 out of your pocket, either through provider visits or prescription drug copays. So now you've met your deductible. So now you're into the 10% co-insurance. So now when you go to the provider, you're still not gonna pay anything. They're still gonna bill Empire that $175. Empire is going to adjudicate it back down to the $90. That's what they're expecting to be paid as payment in full. But now because you've met your deductible, you're into the co-insurance, Empire is gonna pay 90% of the $90, $91. And then provider's gonna see the member owes $9 and they'll bill you for the $9. Okay? And then if you go to the pharmacy, now we're into the copay. So it's gonna be $10, $20, or $40 because you've met your deductible. And it will continue to work that way for the rest of the contract year, unless you hit your out-of-pocket maximum. So if someone's in the hospital for an extended period of time and has a $250,000 hospital bill, say right out of the gate in July or something, as an individual contract, they'll have to pay the hospital $2,425. Then for the rest of that year, July through June, there would be all the medical services would be paid in full in network, and your prescription drugs would be paid in full because you've met your out-of-pocket maximum. So So that's how the safety net would work. And for a two-person or family, it's $4,850. It doesn't stop for one member in the family at 2,425. So one person in the family could meet the whole $4,850. Question? I did work up an example of a knee replacement. Now, I didn't include everything. I didn't include office visits prior to the actual surgery and all that, because obviously there are at least one or two, probably an x-ray or two. Well, maybe I should go back here first. So say, before I do that, let's just say you went to an orthopedic doctor. Actually, I just went not too long ago. And it was a follow-up. So he took an x-ray. So then the orthopedic billed, the bill was over $300, but I think the insurance company allowed $225 between the office visit and the x-rays. So in that case, you met your deductible, you're gonna pay 10%, so you paid $22.50. Okay, but the x-rays were like $75. So now if you go to a knee replacement, the first thing they do, this is for a family, not an individual, this is a family, so the deductible, you can see I have it $3,000. Co-insurance, once the deductible's met, is 10%. Out-of-pocket max, I have the $6,850, but that includes $2,000 from the district, so your true out-of-pocket still the $4,850. The first thing they do with a knee replacement, I don't know if anybody's had one here, but typically they send you some prescriptions, mainly pain meds, to get before you have the procedure done. So in this case, without the deductible's not met, so I'm saying we have the full deductible to meet yet. So those 4 prescriptions, say, were around $320. So that would have come from the HRA, the district funded HRA, so you wouldn't have paid anything at the pharmacy. Then you go for your procedure. And the first bill, actually this is my knee replacement, so the first bill that I received was, our explanation of benefits was the facility fee. They charged somewhere around $20,000, the discounted amount was $14,000. So this would be the tricky one, because with $14,000 is owed to that facility. We used $320, so there's still $1,680 left in the account, so that would go toward the $14,000. That would be $2,000, still have $1,000 in deductible, so then I would have had to have paid $1,000 to meet the deductible. Okay, so now that's $2,680. That would leave $11,320 left to owe to the facility. So then I'm gonna have to pay another 10% of that, $11,000. So that's $1,132 plus the $1,000 for deductible. So I would pay $2,132 to the facility on that. Now the deductible is met. So when the surgeon's fee came in, that was also in the high teens, I believe. But the allowed amount was $8,000. So then you pay 10% of that would be $800. The anesthesiologist fee settled for $1,800. So that would be 10%, $180. And then if you had a prescription for a cane or a correction or something, you pay 10% of that. So overall on this, the procedure costs a little over $24,000 between the district and the member. Their responsibility would be $5,116. So basically the member would have paid $3,116 in this case. Okay, any questions? Now again.
I have a question, with PPO, PPO, would it be the same amount?
Yeah, I was just going there. With the ultimate PPO, the cost would have been the co-pays on the prescriptions. Other than that, this would be paid in full. But again, you need to look at what you're paying for your insurance on the alternate PPO compared to what you would pay on the HRA account. Because there's definitely savings there, so you need to decide, you know, which plan works better for you on a personal basis. This is the same example, I won't spend much time on it, but I'm just saying here that the deductible is met. So in this case, because the deductible was met, the prescription drug copays, instead of $320 coming out of the HRA, you would have paid $60 in copay, saying 2 were generic at $10 and 2 were brand at $20, you would have paid $60. And then everything else would have been the same except it's a straight 10%. So in this case, if the deductible had already been met, the member would have paid $2,444. It's basically the same example.
I have a question about, now, how does Medicare fit in that? Is that after Medicare or before Medicare?
Yeah, this would be, remember, we forgot about Medicare for now.
Oh.
I think now, just a minute, we'll bring up Medicare, okay? The last thing I have before Medicare, there's a fitness reimbursement, and there's a lot of question?
And before we go on there, with that example that you gave about the, surgery, if you pay that $3,000, and I'm not quoting your number exactly, but you pay that $3,000, your responsibility, that goes toward your maximum out of pocket.
Yes, this was, this example here is for a family contract. So in this example, if you were an individual contract, you would have stopped at $2,425.
Okay.
Yes.
And then, hypothetically speaking, you need the other knee done. And that's all covered then at that
Get it done in
point?
the same year before June 30th, yes.
Alright.
Yes. We have family contracts where one spouse may need a knee and one may need a hip, and they're asking, can we do them? I mean, well, you know, if you start in July, August or something, and one gets done and rehabbed, and then the other one, if it's in the same year, that is your maximum responsibility, yes.
And the year runs from when to when?
July through June. So just for everyone, there is a fitness reimbursement, and there's a lot of information. It's only in the HRA, so it's in the HRA booklet. But there's up to $400 reimbursed. Say you want to join a gym, you join a gym. You can get up to, I think it's $200 every 6 months, but you can get up to $400 per year. And it's most any gym, as long as it's basically a storefront, not somebody's basement. And, you know, there's not a network, it's just, as long as they're a qualified gym and they have training for strength training, aerobic training, flexibility, that kind of thing. So any Y, any Planet Fitness, any of these gyms locally should qualify. If you don't wanna join a gym, but you may take yoga lessons or spin classes, what have you, and you pay for them, you can submit your receipts and get reimbursed that way as well.
Say that part again, please.
Excuse me?
Can you repeat what you just said? If you take a yoga class or?
Yeah, so if you don't join a gym, but you're taking classes, fitness classes, or even now online, like Peloton subscriptions, those are now reimbursable. But if you're taking, say, a spin class or a yoga class and you're paying for that, and it's not part, you didn't join a gym, you can submit your receipts for that and get reimbursed for those
For a
costs.
storefront?
Up to $400.
Yeah.
You can't submit in advance, it has to be paid, but yes, you can. You will get reimbursed, yes. Okay, how am I gonna do this? I have some slides that I wish I had here. Medicare. Don't quote me on the numbers because I don't remember them off the top of my head. I know inpatient, there's a copay. If you're admitted in the hospital, the first 60 days, Medicare has a copay of, it's around $1,600. I don't know if it's high 15 or low 1,600, that you have to pay. That's the member's responsibility. So, in that case, I think I'm going the wrong way. In that case, I think, let's stay here. So in that case, say you were admitted, what would happen is Medicare is going to pay all but that $1,600. That, now if you had, say you're on a two-person contract, so you have $3,000 in your HRA account. If there's any money in the HRA account at the time of you're admitted and that liability comes due, it would come out of the HRA. It would pay it. So say you had $3,000 in there, something happened, you're admitted in July, you've got the full $3,000, it's going to take $1,600 out after Medicare pays. And at that point, you wouldn't pay anything. And Medicare is going to pay for 60 days. Then they have co-payments after that, $300 and some a day or something for the next 30 days or whatever. Any money in there would come out. But let's say you're not inpatient. Let's just talk about doctor's visits. So in this situation here, Part B covers the provider visits for Medicare. There's about I think it's $236, I'm not positive, but it's in there. That is a Part B deductible you have to meet every year. You probably don't notice it because Empire picks it all up with the except for the but it is in there. So this plan, the HRA plan, runs July through June. So midway through the year, well, let's just say this is going to start in July, so you've probably met your Medicare Part B deductible at that point. So when you go to the office, they're going to bill Medicare because that is primary because you're retired and you have Medicare. So let's just say in July you've met your deductible, they bill, whatever they bill doesn't matter because Medicare is going to say, we pay you $90. So at that point, if you've met that deductible for Medicare, they're going to pay 80% of the $90. They're going to pay $72. That's going to leave $18 left. Now in July, you may or may not have met your deductible with the HRA, or you may or may not have money in your account. If you have money in your account and haven't met your deductible, okay, there's $18 owed. So if you have money in your account, haven't met your deductible, you're responsible for the $18 because it's going toward deductible. So if you have money in the account, the account will pay that $18. If you haven't met your deductible and there's no money in the account, then you'll pay $18 out of your pocket.
The 10% doesn't kick in?
That's because the HRA deductible hasn't been met yet, so the 10% doesn't kick in. So once you've met your deductible with the HRA, then you go back, so now as a two-person contract, you've met your $3,000 deductible. So now when you go to a doctor's visit here, they're still gonna bill Medicare first. And again, it doesn't really matter what they pay. Medicare doesn't really negotiate rates. They tell providers what they're gonna pay. So it's gonna be somewhere around $80, $90 for a primary care office visit. So they're gonna bill, Medicare is gonna pay based on their allowance. Say it's $90, they're gonna pay 80% of that again. So they're gonna pay the $72, but now you've hit your deductible. So at that point, if there's money, Empire's going, well, you've got $18 owed, you've hit your deductible, Empire's gonna pay 90% of the $18, you're gonna pay $1.80. So it's either gonna come out of your HRA, if you still have money in there, probably not, but if you don't, you'll wind up paying $1.80 because Empire's gonna pay 90% of the remaining balance from Medicare. I have some slides that show it really nice and I feel bad, but, any questions? Medicare questions?
Does the Medicare deductible, the $233, can that come out of the spending account?
No. Medicare deductibles are member responsibility. Well, I shouldn't say that. If there's money, right, because if there's money, I'm assuming for the most part, you're halfway through the year, $200, 2 or 3 office visits. If it hasn't been met, it will come out, yes, because it's part of the member claim. Because if that deductible hasn't been met, Medicare's not paying anything. So then the whole $90 would come down. And then the $90 would either be paid by the HRA account or paid by the member, if there's money in the account. If there's money in the account, they'll pay it. If there's no money in the account, but you're still in deductible, you're gonna pay out of your pocket. If the deductible's been met, then the plan's gonna pay the 10%. They'll pay $9.
So if
So
they have
that-
money in their account, their deductible could be paid for, they could be applying that deductible
Yep.
towards their Medicare as well as their HRA.
They could. Yes.
So if you're healthy and you're on Medicare, HRA is the way to go.
We have quite a few people, on the HRA with Medicare as primary. Because for the most part, your money, unless you get admitted to the hospital, your money's gonna last longer because Medicare is gonna pay 80% up front for most all the other services. Now remember, Medicare doesn't have to cover prescription drugs, so any prescription drugs you have will come directly to the HRA. I'm putting some people asleep here, so what do we have? Any more questions?
I think a big benefit that you probably never heard of, but we have here locally in Lake George is that extra copay or the extra part of the deductible, the 500 or the 1,000, is reimbursed.
Okay. This is the standard plan that I talked about. So if the rest of your deductible is covered, I'm assuming then you probably need to submit an explanation of benefits and either the school reimburses or you have Jager and Flynn or somebody reimburse. I don't know how that works.
Yeah, we have a third-party administrator.
You have a third-party administrator that does that? So in that case, your out-of-pocket max for you, the member, is gonna drop on the individual contract by $500. So you're gonna be $1,925, and it's gonna drop by 1,000. It's full reimbursement. So then it's gonna drop by 1,000. So now you're $5,850. Now you're $5,850 out of pocket on 2-person family. So yes, you have. Well, Lake George has always been known to get a little extra on all their health insurance. So there you go. So my out of pockets, you reduce it by the portion that I talked about that you're responsible with your deductible goes away. District picks that up too.
So for those on
But you need to
Medicare-
submit that. It's not integrated with Empire. So
Right.
it's gonna take a little work on your end because you need to, I guess, submit it to the third-party administrator probably.
So those on Medicare, that makes HRA even more advantageous. If you know what your expenses are. If you're hospitalized, that's a whole different story.
Yeah, but even then, I mean,
Yeah, yeah.
it's around $1,600 Medicare is not gonna cover it, the plan's gonna pick up.
All PPO, it's just a copay.
Actually, at
so-
this point, you don't have deductible, so the plan's gonna pick up the first, they're gonna pay that $1,600, and what's not gonna pay, you're only gonna pay 16, so the most you're gonna pay is $160-some. So, yeah, that's a very nice benefit.
Mhm.
I will tell you actuarially, if you take a large group of people, the out-of-pocket cost for either one of these plans is around 10%. Back when the Affordable Care Act came into play, 2010, they set up four metal levels. You may have heard of them: bronze, silver, gold, and platinum. So the bronze would cover about 6% of a large group of people's cost. Silver is 70, gold is 80, platinum's 90, give or take 2%, so 88 to 92. both of these plans are gonna cover 90% or more, for the most part. And even if you max out, so if you max out on this plan, as long as you stay in network, to hit your out-of-pocket maximum, on the standard plan, not counting the extra deductible, because I'm not gonna do any more math than I have to. So on a family plan, you'd have $1,000 in your deductible that would go toward the out-of-pocket. Then you would need $38,500 at 10% to hit your out-of-pocket maximum. And that doesn't even include if you had any prescription drug copays, because that would be added to that. And combined between the prescription drug copays and your 10%, you would need to reach the $48.50, which is now $38.50. So, but let's just say it's standard plan here. So you need $38,500 at 10% plus $3,000, that's $41,500 in covered services. Your out-of-pocket on a standard plan is $48.50. That's a little over 11%. So you're still within a platinum range for this plan, even if you max out. So either one of these two plans, I'm gonna say, for the most part, are the best in the community. There's with this deductible basically gone, they are the best in the community. Most small businesses buy silver plans. Some offer gold, but they're expensive. And another thing you can do, if you're curious what kind of costs you have utilized, Empire does have an app. It's the Empire Sydney app. You can download information from there, or you can register if you haven't at empireblue.com, and at that point you can pull down your claims history, and you can see what kind of costs you've had for the past few years. So that'll give you an idea of what you spend and how it may work with either plan.
If you're tech savvy too with that, especially for retirees, you could download your claims to a spreadsheet and submit that for reimbursement as opposed to saving tons of receipts.
So yeah, obviously you can find doctors or facilities, you can view your coverage, benefit information, claims history. The Anthem Estimate Your Cost tool, if you need an MRI, you can actually go to there and plug in the MRI and your zip code in a mile radius, and it will bring up the different facilities that offer the MRI, and it will give you an estimated cost for each facility, which is kind of interesting because I'm told they can range from like $800 to $2,000 for the same MRI. So that is something. Obviously, new ID cards and things you can get. And other than that, I don't have any.
So as far as being on Medicare, there really isn't a whole lot of difference between two programs. I mean, I had my hip replaced, we were on the PPL, the alternate PPL, but I mean, it was a few copays with the extent of it. I mean,
Yeah, the alternate is going to cover any hospital services, as I had said with their summary. Anything hospital-wise, the alternate's going to pay in full. So you're not going to see a lot out of pocket there. You might see a little more out of pocket on the HRA, but you're going to see a lot less because the whole deductible is covered. So you're only going to pay 10% of whatever the allowed amount is, or some prescription drug copays, and you're going to have, depending on your contract, either $1,000 or $2,000 to work with in the HRA. So you may not pay anything, depending on
yeah, like I said,
on health
a
here.
few copays,
Right.
we haven't
Well, like I
had
said-
any other doctor visits or anything else except
Like I
for.
said, either one of these plans, you're not going to pay a lot because, like I said, they're platinum plans.
Suppose you wanted to switch to HRA and you decided, no, I'm gonna go back to PPO. Is that a district question? Yeah.
We do currently have two
open enrollment periods per year.
Okay,
So if you try it for 6 months, this is what I'm telling people, if you don't like it, you can switch in January. This is probably the last year that we'll offer those 2 open enrollments, but we want to encourage people to try it. That's why we're doing 2 this year.
But you could switch January, like you could switch
Next
after
year,
12 months, you could
12
switch
months,
that.
right. Next year it will be just every July when you can make the switch.
So Lynn, you're gonna be in your office this week?
did I understand you correctly that there's no copay under HRA?
The only co-pays on the HRA would be for your prescription drugs
Prescriptions.
after you've met the deductible.
Right,
But you have to meet that deductible first. Then everything would be 10%, as opposed to a $50 copay or something. Mhm.
So Fred, we had a comment in the back that if you're on Medicare, you'd be crazy not to take the HRA. Do you agree with that?
If you're healthy.
Well, if you're healthy, I don't see how you're gonna get hurt, because that whole deductible's paid. So basically Medicare is gonna pay 80% of your doctor's visits, and you're either gonna pay nothing because you still have basically $3,000 in that HRA account, even though 1,000 of it's separated by a third-party administrator. But you're gonna have $3,000 there to work with, and when that's gone, or if it's gone, the one thing I will tell you is the 2,000 has to be used first before the 1,000, okay? But if all 3,000 is gone, Medicare is still gonna pay 80%. So if it's a $100 office visit, just leaving $20 left, the most you're gonna pay is 10% of $20, which is $2.
As opposed to a $30 copay on all PPO.
Well, no, because say it was only $20 was left, they're only gonna pay $20. They're gonna pay $20.
But, so if you're
But on the
just in
HRA,
a-
you may pay, there's a good chance you're gonna pay nothing for an extended period of time.
Correct.
And you're gonna pay less for it. I don't know what the cost difference is, but you need to look at that too, because should be some savings there as well, because the rate differential between the HRA and the ultimate PPO is pretty significant.
I think a lot of it too depends on what association you were in and when you retired.
Mm-hmm.
So if you retired with.
Oh, you're right, you may not be paying much of anything on either one of
When you
them.
were in the association, when you retired, if you just paid a flat dollar amount and it wasn't a percent, that was,
Okay.
that was a nice,
Yeah.
nice gig
Okay.
then.
Yeah, I mean, as a retiree, if you're not paying much for either plan, then there's not gonna be a lot of savings, correct? I apologize. Some of the districts now have retirees paying 35% or more, so.
Fred, did you bring change forms with you today?
Change forms, I did not.
Okay, so we have those in our office.
I have some here,
Oh, perfect.
I brought them.
Lynn's got them.
we don't
They're
have
in our
much,
office.
if we wanna change, we don't have much time, turnaround time. You need to, by June 9th, is that correct?
That's correct.
Wow.
So what other information do you need in order to make a decision? How can we help you?
I'm sorry, say that again, please.
How can we help you? What other information do you need?
No, I just have to read the literature, the
Oh,
books here,
okay,
you know,
okay.
yeah.
I would look, Janet, what has your history been? You know, you can't predict if you're gonna have an accident, be in the hospital, whatever. But traditionally, what do you know you have? And look at that
Yeah,
and, you know, look at what did it cost you in your co-pays as opposed to, that's, or maybe not. And it depends what year you retired to.
Back in the beginning when we were talking about
this
PPO,
PPO,
hospital bills,
remember,
just
that
go back
was not that, it doesn't
on
seem
that.
that long
If
ago,
you're in the
we switched to
hospital,
this.
what the deductible is or what your, it's much more than it used to be then. I mean, you would
On the
basically not
ultimate-
have to pay anything in the hospital.
On the ultimate PPO?
We're on PPO now, yeah.
Yes.
All PPO?
Alternate PPO.
Yeah, all PPO.
So, in-network hospital, it's paid in full.
But in the HRA, comes out of it, the deductible.
In the HRA, it would come out of the HRA it's $1,600, the deductible's paid, so if you paid anything toward that inpatient admission on the HRA, it would be 10% of the $1,600, or $160 some dollars. But you're right, on the alternate, it would be paid in full.
Any other questions? Right here?
Yeah. My question is, there more things to keep track of on the art? HRA.
Well, most of that is done by Empire, because it is integrated. The one part you'd have to keep track of would be, once you've used the $2,000 from the HRA, you have another $1,000 you're gonna need to submit to the third-party administrator. Okay, other than that, I don't think you're really gonna see a lot of other work.
Could be less. I'm on HRA and I submit one time, get my $1,000 and be done. And, I mean, it's a pain keeping track of all of that stuff, so.
But you're saying you get it on the site?
You could get it right from the site. So on HRA, if you get to that point, if you get past your deductible, you submit, and then you don't submit the rest of the year.
Right.
You submit it one time as opposed to every month or every 2 months submitted.
Yeah, I guess it depends on how you wanna do it, or you can just save your explanation of benefits, cause that's gonna show you member responsibility after the deductible is met too.